Hello, everyone, and welcome. My name is Miriam Mutebi, and I'm the Vice President East Africa for AORTIC and a breast surgical oncologist by training. Today, I'm very excited to share a little about the Surgical Oncology Special Interest Group and reasons why you absolutely need to join, and perhaps make you feel a little envious about what you'll be missing out on if you don't. The Global Surgery Commission in 2014 painted a rather dire picture. Ladies and gents, what they actually said was that 5 billion people on the planet have no access to safe, affordable surgical and anesthetic care. And while that might sound a little esoteric, what we actually mean is that 9 out of 10 people on the planet have no access to surgical care, to safe surgical care. Now, though while it might not necessarily be intuitive, most of us might think, well, what does that have to do with oncology? This is a question that the Global Cancer Surgery Commission in 2015 tried to address. In 2015, we showed that about 15 million new cancer patients were diagnosed, and it was projected that by 2030, at least 48 million cancer surgeries would be required to meet the growing emergence on diagnosis of new cancer patients. Now, what most of us may not realize is even currently, more than 80% of all cancer patients at some point on their treatment or cancer journey, whether it's in the diagnostics, in the supportive, in the palliative, are going to require a surgical procedure. And more than a third of patients are going to require multiple procedures. This is because surgery is one of the major pillars of cancer care and control, and it can be preventative. For instance, when one goes and excises a polyp, it can be diagnostic when one takes a biopsy. It can be curative when we resect a tumor with negative margins. It could be supportive or palliative, for instance, when to improve the quality of life, one could do a toilet mastectomy, and it can be reconstructive, for instance, when we have to cut out large tumors, say from the head and neck area, or perhaps when doing a breast reconstruction following a mastectomy. Surgeons do form a critical part of the healthcare workforce and are involved in making diagnosis, surgical treatments, sometimes in rare situations where there's not enough oncologists on the ground. Surgeons may occasionally administer chemotherapy, but by and large, as a continent, there have been very few large scale efforts in order to improve access to oncological surgical care. Health workers in sub-Saharan Africa, we do tend to have the largest healthcare worker deficits, but this also translates more intimately into surgical oncology capacity. And recent studies showed that failure to train more cancer surgeons and strengthen systems could result in as much as 6.2 trillion loss in the gross domestic product by about 2030, building, I would say, an economic argument as to why these services need to be improved. And we recognize that these solutions need paradigm shifts in terms of our thinking, rather than thinking of investing in surgical oncology services as as expenditure. Look at it more like building a framework in which we're actually likely to see better improvements in all spheres of cancer care. There is a need to look at how do we improve the diagnostic and supportive aspects of care. How do we set up multi-system approaches? It's not just one size fits all, but how do we look at how can we collectively, as a regional or continental community, strengthen the surgical services we're providing to our patients? There's definitely a need for surgical advocacy, and surgeons really should be at the forefront of advocating for change. And there is a need to develop communities of practice and knowledge exchange, and to look at basically interrogate our patient populations, look at how our patients are doing, and see how can we improve the surgical outcomes that we currently have. There is a need to develop more extensive knowledge sharing, both in the South-South and with international collaborations. And I would say that women have a unique role, especially in Sub-Saharan Africa, in the surgical workforce in order to reduce some of the stigmas and barriers that we have for women accessing care in Sub-Saharan Africa. So our roadmaps are very simple, and we're looking to focus around research and training. We've had a couple of surgical pathology preceptorships, and we're knowledge exchanging, and we're hoping to expand this. And we're hoping ultimately in time to extend these to patient care initiatives. Our priorities around how can we improve our systems, both in terms of documentation and ultimately migrate to electronic records, looking at what kind of reflective practices can we have as a surgical community, looking at regular audits, outcomes research, and pooling resources to actually look at how can we improve outcomes for our patients. Definitely, there's an emerging role for centralization of surgical oncology services. Urologists have led the way in West Africa with developing centers of excellence and looking at how we can percolate that to the rest of the continent and looking specifically at key areas around education and training, particularly for women's surgical oncology teams and multidisciplinary groups, and looking at investment in the supportive services, which includes both pathology and imaging. In conclusion, surgery must be at the heart of the global and national cancer control planning, and surgical advocacy must adopt a multi-systems approach. And so the surgical oncology interest group is not just limited to surgeons. We need all comers. We need pathology, we need diagnostics, we need nursing, we need policymakers, and all of this is to try with a common goal to strengthen the provision of surgical services on the continent. Innovative approaches are key, and the special interest group will provide a forum for knowledge sharing and amplification. At the end of the day, the end result is hoping that will give our patients reasons to smile. Thank you.